Now, as you will notice, the second part of ST300 is where we start to get closer and closer to what you will be actually doing in the operating room. Okay. So today we have chapter 9. We have a Quizlet. We have a couple videos that really break down what we do. Now, keep in mind, trust the process. I know, especially in our field, a lot of it's hands on, like the majority of it is hands on. But trust the process. Modules 2 and 3, we're building you up. We're setting the foundation. Okay. And I know you're like ready to get in there and do your scrub and do everything, but we're going to learn the foundation first. And that's really what we're getting into. Okay. We're talking about sterile technique and infection control, two things that are extremely important in our field. I cannot stress this enough. If we can't grasp this, then it's going to be harder when you get to the next step. And then it's going to be even harder when you're in the lab. And it's going to be even harder when now you're in the OR setting with real patients, with real staff and surgeon and nurses, and real blood and bodily organs and everything. Okay. So, like everything, we have our learning objectives. Okay, so we're going to be looking at guidelines related to sterile technique. We're going to definitely look at terms related to sterile technique. There is an importance with barriers of containment. That's huge in our field because there's going to be times where you're going to be multitasking. You're going to be watching the door. You're going to be watching the field. You're going to be making sure no one's coming near your back table. You're going to be monitoring your mail stand all while still assisting the surgeon. In some cases, it may be you and that surgeon, and you're holding instruments, you're holding retractions and still passing instruments. Trust me, it happens. Been there. Okay. We also are going to look at a couple videos on gowning, gloving. I have a video. I don't know if everyone was able to see the one I sent. I have another one that is really just going to set you guys up for the field. Okay. We can't watch it here. It's 28 minutes, but I am going to send it to you where I kind of break it down. Okay. From opening your room to, well, before you even open your room, cleaning your room, because we wipe everything down, to checking your case card, to opening up the items, looking at what you're actually doing, your surgical scrub, and then opening up your case. All right. But like I said, we have a couple of shorts today that we're going to watch. But like I mentioned, this is the foundation. Without this, it's going to be harder moving forward. So the first thing we talk about is aseptic technique. Now, this is the practice designed to prevent contamination and the introduction of pathogens to our sterile fields. This includes everything from properly preparing and draping the patient to handling instrumentation, supplies, sterile, using everything in a sterile aseptic technique. Every step taken to ensure the environment remains sterile plays a huge role in patient safety and surgical outcomes. Our biggest thing is trying to prevent surgical site infections. It's a primary responsibility of all of us in the surgical tech world. We have to maintain our sterile field. And that's not just your mail stand and the field, meaning the surgical site. It's monitoring, like I said, that back table. There's going to be some times where you have multiple tables, especially if you go into total joints or you go into orthopedics or neuro or cardiovascular. You're going to have more than just one sterile setup. So you're monitoring all of that. Go back to that very first video that I showed you in module 2 and that we rewatched in module 3, right? Where that assistant, now you're seeing it differently, right? Now that we've moved closer and closer, your eyes are getting more sharp, okay? Keep in mind, you're going to hear me say this a lot. Trust the process, okay? The biggest thing is we're trying to minimize these risks because we want better patient outcomes. So we create and maintain our sterile fields. We are responsible for setting up and maintaining the sterile field, right? This means that we have to understand our boundaries. We have to know the difference when it comes to our sterile and non-sterile areas and be careful when we manage our instruments. I muted myself. Thank you guys for telling me. I'm like just going on. I love technology. Okay, so here we are. This is the meat and potatoes of what we do. Okay, as surgical technologists, we roll with it. Things happen. Okay, we can't let it get us down, but we keep it going, as you guys can see. Okay, so this is going to be important. This is going to be vital in order for you to move on. All right. Now let's keep going just in case my computer acts up again. There are a couple of recommendations that we will always adhere to as surgical technologists because our goal is to prevent SSIs. Okay. We have to improve preoperative care. We follow the CDC's hand hygiene guidelines. There is a certain way you're going to learn how to scrub your hands. Okay. And it is sometimes you're going to be thinking like, man, we're counting everything. Yes, we are because we're trying to reduce the amount of microbes on our skin. Your skin cannot be sterilized, but we can surgically um, reduce the amount of microbes so that you are surgically clean. Okay, so just keep that in mind. We also use evidence-based practices, research on surgical site infections guides improvements, especially in our environment. We know that we work with blood-borne pathogens. So we follow OSHA standards because it provides safety procedures, especially as we're handling sharps, knives, scissors, bovie pencils. All of these things can cause the transfer of blood-borne pathogens. Okay. We also have what's called an MMWR, which is, as you guys can see, morbidity, mortality, and it's a weekly report where it reports on all of the surgical site infections and preventive measures. And again, we're just trying to improve our surgical practice. When we talk about Society for Healthcare Epidemiology of America, or SHIA, this offers guidelines for just managing antimicrobial use. Again, what are we trying to do? Prevent infections. And then the last one you see up there is professional organizations like AORN and AST. Now, AORN preoperative standards and AST standards of practice, they really, again, guide infection control and sterile field management. All right, so we've got all that out of the way. Well, we've got some key points that we got to break. Sterility, sterility, sterility. If you don't remember anything else, when in doubt, throw it out. When in doubt, throw it out. And this isn't just for the book. This is when you're in your field. Okay. If you have the opportunity to watch the draping that I did with me and my other coworker, you'll notice that we did a laparotomy and we did a lithotomy. So laparotomy was when the patient was on their supine, and lithotomy when they were in the stirrups. And when in doubt, they said it was contaminated. We threw it out. It did not matter. In your mind, you're probably thinking, I did not contaminate. It doesn't matter, because some people can see stuff that maybe you didn't notice. And it can be as quick as a little brush, something that you don't even feel, and then your field is contaminated. And then those pathogens have the potential to get into the surgical site. So when in doubt, throw it out. Now, we break down sterility. When an object is sterile, it is completely free of all living microorganisms, including spores. Sterility is an absolute state, and that's why skin cannot be sterile. Okay. So it's either an item is sterile or it's not, point blank. Now, sterility is maintained by aseptic technique, which just makes sure that no contamination occurs during handling, transport, or use. When you hear the term non-sterile surfaces, any surface that is not sterile is considered potentially contaminated. So there's that risk of a patient potentially getting infected. And there goes that SSI. So we, as surgical techs, must carefully manage all non-sterile areas to prevent infection. And we do that as soon as we walk into the OR suite. All right. Now, contaminated objects. Okay, let's think about it. An object or body tissue that is not sterile or has come into contact with a non-sterile surface or item is going to be contaminated. But we have to differentiate contamination from gross contamination. So I have an image up there. Now, the contamination of a surgical wound or sterile site by a highly infectious source, which can spread to infections. So we think of the spread of microorganisms through direct contact, moisture, dust, droplet, nuclei, which is why, if we think about it, maintaining aseptic technique is so important for preventing contamination in the operating room. We look at examples of gross contamination. So it's an event in which a sterile item or surface has come in contact with non-sterile items or surfaces. For example, you have a patient coming in and they're complaining of right lower quadrant pain. They have elevated white blood cells. As an ST, I'm thinking, oh, okay, this is a potential appendicitis. So we're going to bring this patient in for an appendectomy. Okay. Now, if an appendix has ruptured, spilling pus into the abdominal cavity, gross contamination of the peritoneal cavity has occurred. Why has it occurred? What just happened? Think about the contents of the appendix. Okay. Pus, gross bile, different things. Okay. In a ruptured appendix, we think more about not just getting out the contents, but now irrigating the peritoneum, because you don't want that contamination to just be sitting in the body. Okay. We're going to bring the patient in. Where most likely we'll either do an open appendectomy or laparoscopic appendectomy, just depends on the surgeon and surgeon's preference where they were trained. And we're going to really flush out that peritoneal area. Okay. Surgical conscience is another huge thing. The ethical and personal motivation that regulates behavior behavior regarding disease transmission is rooted in professional responsibility. This involves ensuring patient safety by adhering to infection control protocols and maintaining a sterile environment when someone is there and when someone is not. So, what does that really entail? You're admitting the reporting in breaks in technique. Demonstrating integrity by openly admitting and reporting any lapse in sterile technique. And that shows a high level of professionalism, maturity, and a strong surgical conscience. That goes back to when in doubt, throw it out. If I'm not sure, I'm going to get rid of it because I don't want my patient to be contaminated or infected. This also makes sure that corrective actions are taken, minimizing risk and maintaining safety and the well-being of the patient. Not here to scare you guys, but if you do not have a strong surgical conscience, it's going to be harder for you to be able to move on. Okay. Remember that you're also the patient's advocate, which goes hand in hand. There are going to be times when you as a surgical tech are going to step up and see something, you see it, you say, you see it, you say it. Okay. If something drops below the waste level or the sterile field, you call it out. Because at the end of the day, again, you are the patient's advocate, right? You're there because the patient cannot speak for themselves. Most of our patients are intubated and put to sleep. Okay. Does that make sense? Okay. All right. So, talking about aseptic technique, the method of doing and thinking in surgery. Now, this just refers to the disciplined approach and the mindset that we use in the operating room just to make sure that our patients have successful outcomes during all of our procedures. It involves following established protocols, techniques, again, like aseptic technique, to just minimize the risk of infection during surgery. The technique itself is grounded in understanding how microorganisms spread and implementing practices that prevent their transmission into the operating room. And this is why you guys got that foundation of microbiology in module 2. So you see, we're building you up. We talk about containment, preventing the spread of microorganisms by isolating them from sterile areas, which is different from confinement. And I have seen questions on the AST or the CST on confinement and containment. So it's going to be really important to differentiate the two. Confinement, ensuring that contamination is limited to specific controlled areas, preventing it from affecting the surgical site or the sterile field. I cannot stress you really want to be able to differentiate containment and confinement. Okay. Now, we get concepts of barriers. The principles of aseptic technique revolve around the idea of creating and maintaining barriers between sources of contamination and sterile surfaces. This is why we use our blue drapes, okay? Because we, in the surgical realm, when we see blue, we know that's sterile. We stay away if we're not scrubbed in, or we stay around it if we are. The practice prevents the introduction of harmful microorganisms into the sterile field, which again helps to reduce infection. So we have physical, chemical, distance barriers. It helps us as a team protect both the patient and ourselves from being contaminated during surgical procedures. Let's break it down a little bit more. Okay. We have our physical barriers right here: gowns, gloves, your hair cover to prevent your hair from falling into. If you have a beard, we have beard covers in some cases. We have our shoe covers. If you're going to be in a lot of arthroscopy cases, we have the longer waterproof shoe covers that kind of go up to your knees, just to prevent or to have that physical barrier between a contaminated source and a sterile surface, again, preventing contamination. I come over here and I put up this chemical barrier right here, right? Our antiseptics, our disinfectants. We're trying to reduce or eliminate. Remember, skin cannot be sterile. So we're trying to reduce or eliminate as many microorganisms from surfaces, providing an added layer of protection. And then this last one, you can't really tell because of our distance, but we're actually using distance. Your tech, you may not, it'll make sense when you're there, trust me, okay? But she's watching. She's watching her field, she's watching her circulator, and they're keeping distance as she is giving her items and placing it on the field. This is our distance where we're maintaining an appropriate distance between the sterile and non-sterile area. That's going to be important just to avoid contamination through airborne particles, or in our case, we're looking at direct contact. All of these barriers, whether it's physical, whether it's chemical, whether we're using distance, just helps maintain a sterile field and prevent infection during our surgical procedures. By any chance, do you guys know the minimum distance between a sterile and non-sterile surface or item? Because this is a question that you will see on the CST exam, and it may pop up this week in week 7. Does anyone know the distance? Or take a guess. Close. I'm like doing the math in my head because I see what you wrote. Hold on, I'm gonna send this to you really quick. So when you answer, I will send you. Okay. All right. So you guys be thinking about it. Start typing in what you think. Okay. And then once you send me a message, I will respond back. And this is to kind of get us all involved because this is really important, y'all. I cannot stress. Okay. So you'll notice, like, if you respond, I am going to be responding back. I'm trying not to miss anyone. Okay. Hold on. Okay. You guys keep guessing, keep guessing. And at the end, I will put it for everyone else, but I want to make sure I get everybody. Okay. All right. The other thing that we have are unrestricted and restricted zones. Okay. And this is really important too. One thing about us as surgical techs is we're like our own group of people. All right. So we have our unrestricted zones. This is an area where personnel can move freely without any special attire. This is why I put in like the waiting rooms, administrative areas. It's typically the entrance into the OR suite. A lot of times we have a card code. We do our card code to come in. Okay. Then we get in and we have our semi-restricted zone. And it's semi, but we're still pretty protected. You're going to have on your hair covers, you're going to have on your gown, not your gown, but your overprotective jacket. You're going to have on shoe covers. And of course, we're wearing our scrubs. Okay. Now, this is going to include hallways, corridors leading to the restricted zone where the OR and sterile supplies are actually located. Then we enter our realm. All right. In this particular case, we're completely prepared, okay, because we're actually doing surgery. But if we're just setting, like if we haven't set up our room yet, we wouldn't have on our mask yet, but we would have on pretty much everything else. Once we go open and once you get into the lab, we as a scrub will let the person know, hey, I'm opening. And that's just a cue for everyone to put on their mask. Okay. Now, our restricted zone, this is going to be the area directly surrounding the sterile field, like the operating room itself. So only authorized personnel wearing full sterile attire. So that's gloves, gowns, masks, and shoe covers are allowed in the zone because we're trying to maintain sterility. All right. With that, the air has to flow a certain way. So we have a HVAC, heating, ventilation, and air conditioning, and that's going to play an extremely important role in infection control in the operating room. So that means temperature and humidity is important. Maintaining specific temperature and humidity levels, typically between, and you will see this again, 68 to 73 degrees Fahrenheit and 20 to 60% humidity. I have seen this question on a CAST exam. 68 to 73 degrees Fahrenheit and 20 to 60% humidity. This helps to just prevent the growth of microorganisms. It keeps the OR environment comfortable and controlled for both the patients and the staff. It's usually pretty cold if you aren't scrubbed in. Okay. Now, the air in the operating room must be exchanged several times per hour, usually 15 to 20 air changes per hour. I'm going to repeat that. Usually 15 to 20 air changes per hour, and that's to remove contaminants. So, your HEPA, which is your high efficiency particulate air filters, are used to trap microorganisms and particulate matter. We also have positive air pressure in the operating room, and this helps the airflow from the sterile areas to less sterile ones. Again, preventing contamination from outside the room. Proper airflow patterns help direct airflow away from the sterile fields and minimize the risk of infection. And so, if you look at the image, it breaks it down for you. This is our sterile field. This is where our patient would be, and we're moving away. Okay, away. But hygiene is really important. Now, bacteria residing in open sores can be really resistant to hand washing. So, we emphasize the importance of just making sure that anyone in the operating room, perioperative personnel, have no open wounds or infections on their hands because that can lead to patient contamination. And I know you're sitting there thinking, but wait, I'm wearing gloves, I'm doing the surgical scrub, but nothing's foolproof. Okay. Even when I double glove, there's still always the small possibility that something can puncture my gloves, right? And if I already have a wound, okay, so think about it, have a wound, even with my gloves, I get punctured on, let's say, a Wheatlander. Can happen. It gets snagged. No fault. You're just doing your thing, right? It goes through both gloves and gets onto that sore wound. But that Wheatlander was just used on a patient. So whatever that patient has or could have had, remember we treat every patient the same, like they have everything on earth. Now I potentially do, okay? And vice versa. So these are just different things that we think about. There's another reason why we don't wear rings and bracelets. A lot of us will put our like wedding rings or anything on our necklace around our neck and kind of just tuck it into our scrubs. Okay. Why? Well, microbes can thrive under rings and bracelets, making them difficult to remove through regular hand washing. This is why jewelry should be removed before entering the operating room, just to reduce the risk of transferring harmful bacteria to the sterile field. I have had patients, or not patients, I've actually had students when we were doing the lab and they did a perfect hand scrub and failed the hand scrub. And one of the things, and I'm not even joking, one of the students, I was like head down because I was rooting, but I'm like, ah. And if you catch it during the lab, of course, we make mistakes, we catch it. Unfortunately, the student did not catch it. But when we told them, it was like, what is one of the first things you do before you hand scrub, before you really do anything? And the student looked down and was like, ah, and I was like, yeah. So this is why, because bacteria, microorganisms can kind of hide. Okay. Now, all perioperative personnel should be free from being sick, right? You don't want to bring something in and you're contagious, now you're spreading it. And you don't want to have your mask on because when you're coughing, our first instinct is to turn our head. And I'm not sure if I share this with you guys, but in the operating room, it's opposite. You stay forward because then whatever you're coughing is going to go back. Okay. That means you're sneezing, everything is just in your mask. But you don't want to turn your head because anything out could potentially get into the field. Okay. So we really don't want sick people in the operating room for that reason, right? We just want to make sure that everyone's healthy or as healthy as can be because we want to maintain a safe and sterile environment in the operating room. All right. So why do we hand wash? Well, I mean, it's one of the basic things we do, right? Because we want no one to get sick. We don't want to pass anything. But hand hygiene is the most effective way to prevent transmission of microorganisms and to reduce the risk of infections in healthcare settings, particularly in our operating rooms. So this involves washing our hands with soap and water to remove dirt. And there's a certain way that you guys are going to learn to do it. We're getting rid of debris. We're getting rid of any transient microorganisms. It is performed before patient contact or after touching potentially contaminated surfaces. We do a traditional surgical scrub. This is a thorough hand and forearm cleaning process using antiseptic soap, scrubbing for several minutes, and it is done before any surgical procedure to reduce the microbial load on the hand. You hear me saying reduce, right? Again, skin cannot be sterilized. We also have the surgical hand rub. And some of you should be asking, wait, we have the option? We will get into that. So your surgical hand rub involves using alcohol-based hand rub. And yes, there's a certain way we do that as well, where you're sanitizing the hands and forearms before surgery. It's quicker, it's more efficient, it's an alternative to the traditional scrub, especially when no visible dirt is present. However, it is a requirement that you still do a hand scrub before you like each before each day. So a lot of times what we do is as soon as we come in, we check our boards, or at least this is what I would do. I would go in, I check the boards, and then I automatically do my hand scrub. And then that way, before my cases, I can go in and do my hand rub. Okay. But I still do that initial hand scrub as soon as I walk into the operating room suite. Okay. So we look at the difference. You have routine hand washing, soap, water, you're just removing dirt, debris, microorganisms. Performed frequently. Like we always are washing our hands. Okay. A lot of us have dry, cracky hands. We use lotion, but your hands, we try to get as much of that off. Okay. Particularly before and after patient contact, after touching potentially contaminated surfaces or objects. You have your surgical scrub. So I'm just going through the differences. Your surgical scrub, we have a pick, we're going through our nails, and we're really using antiseptic soap. We're scrubbing every part of your fingers. The video that I have, I think I was racing one of the students. I'll show you guys where they wanted to race me and we raced. And then you have your alcohol rub, okay, where you are following the manufacturer's um, suggestion. All right. It's quicker. We're still going up to the forearms. You're going to up to the forearms in the surgical scrub as well as the surgical rub. You're used before surgery as an alternative to traditional scrubbing and after surgery when the hands are not visibly dirty, providing a quick and effective way to sanitize. I mentioned the fingernails. Nails should be kept no longer than 1/4 inch to just prevent injury or the retention of microorganisms. Okay. Per the book, facilities are going to be a little different. You're going to see some stuff out there, but per the book, nail polish should not be worn as it can chip and harbor bacteria. Per the book. Artificial nails are prohibited per the book, as they can increase the risk of bacterial growth under the nails. And you're going to hear me start saying per the book as you guys get closer to module 4, because there is a difference between the book, real world, and like there's an in between. Okay. But when it comes to the CST exam and when you're taking these tests, we go by the book. All right. When we talk about hand hygiene, again, you're inspecting the hands for visible soil, dirt. You make sure that they're clean. You remove all jewelry, including rings and bracelets. I want you to be thinking about my one student. She was able to retest test and she passed, but just think about that one student and how her scrub was almost flawless. And if you ever get in the lab with me, you know that's pretty hard to do. And hers was almost flawless, except she had on a bracelet. Okay, so be thinking about that. You want to remove all your jewelry, rings, bracelets, because why? They can trap microbes, they can hinder effective hand hygiene. All right. At the beginning and end of each workday, to remove any potential contaminants from the day and before starting work, we wash our hands. Before and after any contact with the patient, we wash our hands. Between contacts with potential contaminant areas, again, we wash our hands. Before contact with sterile packages, in the video that I'm going to share with you, the 28 minutes, I'm going to talk about it. Whenever the hands are visibly soiled, again, we wash our hands. Before performing the surgical hand rub, just to ensure hands are clean and before applying the antiseptic. Immediately after contact with blood or bodily fluids, regardless of whether gloves were worn. Please always wear gloves, but you want to reduce the risk of infection after exposure to potential contaminants. Before, after eating, going to the restroom, we wash our hands. Okay. I felt like a broken record there. So we get into our scrub suit. This is worn by all personnel, and we're just trying to maintain a sterile environment, prevent contamination from wearing our street clothes. You'll notice you see two different types of hair covers. You have options, depends on the facility, because some facilities have a little bit more money than others, so you may have more options. Um, you have your shoe covers, and I've got to find some of those ortho shoe covers for you guys so you can see. I'll try to find those while one of the videos are playing so you can see the difference. But you have your shoe covers. You have eyewear and face shields. So for those of us that wear glasses, they do have shield sides that you can wear. Um, you do have shield covers, and then we have masks that have the shield with them. All right. You want your eyes protected. You don't want blood or bodily fluid squirting into your eyes because it can happen. All right. There's flying debris, especially if you're in orthopedics or you're in vascular and things are happening pretty fast. Blood, bodily fluids can end up in areas that you do not want them to be in. So, eyewear is a must. Of course, we're wearing our masks because we are trying to prevent respiratory droplets from contaminating our sterile field. Every time you talk, there are droplets that coming out, even if you can't see them. Now, you'll notice that one has on a jacket and one does not. We have our jackets to be worn in the operating room for additional protection in certain procedures. Some facilities require you to wear a jacket when you're opening your sterile field. So just keep that in mind. Once you get to your externships, you'll know your preceptors are like, hey, this you have to wear your jacket, okay? And then you have your lab coats and cover gowns, just for a little bit of extra protection. All right. Again, here's a breakdown straight from the ebook of the surgical scrub, but you guys are gonna have a video to kind of break that down on the steps using your fingernail pick and everything. All right. But the biggest thing is we're trying to just eliminate the microorganisms and It helps to maintain sterility. So figure 9.5 kind of just breaks down the typical steps involved in a picture, which I get it. Pictures don't give it justice, but again, trust the process. Okay. Trust the process. More pictures. You're still looking to make sure that the hands, washing them thoroughly, including the areas in between your fingers. Okay. You're getting every surface. Okay. And you're trying not to go over a surface. Okay. And you see how I'm getting here? We go for our palms. We go the back of our hands. Okay. You come down and you're just getting every surface. Okay. And then your elbow. All right. The other thing is you're going to dry your hands thoroughly before applying any type of antiseptic if that's the route you're going to use. Okay, so we broke it down. Here's where we get into the videos, okay? Where now you'll be able to really kind of get that visualization on gowning and gloving. There's times where you're going to gown and glove yourself, okay? You're going to gown and glove other members of the team. There's times when you may contaminate your glove and your circulator is going to remove the glove and then you have to re-glove. Sometimes when the case is going on, you're moving quickly, you're moving urgently, and you're protecting your sterile field at the same time. Okay. And then we're going to talk about bloodborne pathogens and just procedures used in transmission-based precautions. Okay, so we look at hand drying and gowning and gloving. We proceed to the gowning and gloving table once we have finished our surgical scrub. We remove the towel by grasping only the edge, lifting up and away from the table. We allow the towel to unfold. You're going to see all this. We keep it in front of us just to avoid touching the scrub suit. We blot the skin. We don't go like this. We bend over and we blot. Okay. Once we're done, we take it, we go back underneath, and then we blot. Okay. We don't do this motion. Okay. You're blotting. You're blotting. Okay. We dry the second hand the same way. That's how you saw me. All right. So let's watch this video to kind of bring it together.
Now you can put on the gown that is lying in front of you, folded inside out with the collar and one of the two shoulder areas visible. Pick up the folded sterile gown so that it can't unfold on its own. Hold it securely in front of you and step away from the sterile area. The collar should be at the top. Now reach into the inside shoulder areas with each hand in turn and hold the gown in front of you with outstretched arms. Stand so the gown can't touch anything when it unfolds. Then, allow the gown to unfold by itself, making sure it doesn't touch the floor. If it doesn't unfold easily, try giving it a gentle shake. Once the gown is fully unfolded, carefully slide your arms into the armholes one at a time. You can slightly raise and spread your arms to guide each arm through the sleeves. Since you're going to use the closed glove method to put on your gloves, make sure to keep your hands completely inside the sleeves for now. Keep them at shoulder height so you don't touch anything and so that the gown doesn't slide back down. At this point, you'll need some help. Ask an assistant to pull the gown all the way over your shoulders and to help fasten the back and waistband. Keep your fingers inside the cuffs. Now we'll show you the closed glove method. First, unfold the sterile paper package and press the edges down so they don't fold back again. Grab the right glove with your left hand. Now place the glove on your right palm, flipping it over so the fingers point towards you and the thumb is on the correct side. With your left hand, pinch the part of the cuff facing up, and with your right hand, pinch the part of the cuff facing down. Next, use your left hand to pull the glove over your right hand and the gown sleeve. When you pull back the gown sleeve, the glove will pull back with it and let you slide your hand into the fingers. Done! Do the same with the left glove. Turn it, put it on your left palm, grab part of the cuff facing down with your left hand and the part facing up with your right hand. Pull the glove over your left hand and sleeve, pull it back with the gown, and slip into the glove. Finally, the surgical gown has to be secured. If you'd like to look at this straight away, just skip to the last section of this video. Otherwise,
All right. And we're gonna break this video down so we don't have to skip, okay? Um, does that make sense to everybody before we move on? Okay. Like I said, we're breaking it down. So oftentimes we are going to gown our surgeons, we're going to gown our assistants, we're going to have other individuals that we may have to guide them as well. Okay. So let's watch the second part.
Guys, we'll first look at how the whole thing works when you have an assistant to help you gown and glove. The sterile gown will often already be held open for you by an assistant after you scrubbed in, especially in the OR setting. All you have to do is slip your arms into the sleeves, and the gown is pulled up over your shoulders and closed at the collar and back. The wrists should remain covered by the gown. Keep your hands in front of your chest so you don't accidentally touch anything and the gown doesn't slip back down. Now it is time to get your gloves on. The assistant will often stretch the right glove open for you so you can easily get your hand in. Slide your hand in with the thumb adducted, then spread your fingers slightly. The assistant will then pull the glove all the way over your wrist and the gown sleeve. Next, the left glove will be handed to you. Stretch the cuff open with your right hand and pull it on. Again, keeping your thumb adducted initially as you slide your hand in. Now, secure the gown. The technique is always the same, whether you have self-gowned or gowned with assistance. Grab the paper tag hanging at waist level and pull off the left tie. Hold that tie firmly in your left hand and hand the paper tag to your assistant. Then do a counterclockwise turn, making the tie close the gown. Grab the end of the other tie, taking care not to touch the tag itself. Pull the tie off the tag, tie a bow, and your gown is secured. Now that you have your gown and gloves on, it's best to keep your hands clasped to your body at chest height while you're not actively using them. Great! Now you're fully gowned.
All right. So before we go to the next one, I saw a question that I wanted to answer. It says, is it better to size up for gowns so that our hands don't accidentally go past the cuffs, or do gowns normally give room in the sleeves so that that doesn't happen? Great question. The good thing is they are very roomy. Very roomy. Usually the gowns that come with your packs will fit almost anybody unless you're like 6'4" and like a linebacker. And then we have extra like large gowns for them. But for the most part, the gowns are very roomy. So you will definitely be able to not have your hands come out once you gown yourself. So great question. Great question. Like I said, this next part is really about visualization because I know that at this part, everybody's ready to get in there and do it. But have a little bit of patience because you're almost there. Sometimes our gloves get contaminated when we are scrubbed in or even when we're setting up. Per the book, and you'll understand once you get to your sites why I'm saying this. Per the book, you do not remove your glove yourself. Again, there is a difference between real world and what you will see, okay? But once you get ready to take your CST, I want you to kind of revert back to the basics because that's what's going to help you be successful for that CST exam. So, your circulator will remove your gloves for you. All right. You want to make sure they have on gloves, especially if it's during the case, because if you were in, let's say, a bowel case and you remove necrotic bowel and all the stuff that goes with it, and your glove is contaminated, and now your circulator has to remove that gown with whatever else is on it, right? You want them to be protected as well. Okay. Circulators are normally going to have that, but just in case you may have someone new that is new to the entire OR world. Okay. So you hold your hand out, they'll show you. You'll also notice that she's double gloved. Like I mentioned, a lot of us, especially when we do a lot of neuro, ortho, cardiovascular, we do tend to double glove. Okay. And your bottom gloves are usually going to be a little bit thicker. Just depends on one, your own preference and your comfortability in certain surgical procedures. Okay. So let's watch removing a contaminated glove.
Okay, so now if you contaminate your glove, you accidentally touch something, again, every time something is contaminated, you announce it and hold it away from you. So instead of you removing your contaminated glove yourself, because you will then contaminate your other glove, your circulator, the non-sterile person, will remove it. The first thing they're going to put on, though, is exam gloves, because they don't want to be exposed to what is on your glove, because you've been touching the instruments that's been in the patient and things like that. So they're going to present their hands, if it's one or both, up like this. So your circulator is then going to grab only on the glove, because you will be double gloved, only on the outer glove, and they're going to pull it down as best they can without touching your under glove. That way, now this is trash, and they will remove that, and now that is still sterile because that was underneath your other glove. So now the circulator will open up a second set of gloves for them to place on top. So now you're back to being double gloved and everything is totally sterile. So if you contaminate your glove, it has to be the circulator that removes it while they are wearing exam gloves.
Does that make sense? Okay, perfect. You will also be tasked with how, like, we're going to look at how you remove your gown and glove as well. Again, we just do not want anyone to get anything on them. It's a good practice just to make sure that you're not taking anything home to your family. All right. So what you're going to see is how we grasp the gown, releasing it at our shoulders. We kind of snap it from our waist, and then we pull the sleeves downward and roll the gown inside out. Um, we are trying to just make sure that anything that was on top of ourselves, like blood, bioburden, anything, stays in that rolled up area as it comes out. And then we dispose the gown in the biohazard bag. There's also two ways. Some people remove the gloves with the gown, and some remove the gloves without the gown. The biggest thing is whatever the book says, that's how you really want to do it, okay? But it's always going to be glove to glove, skin to skin, where you remove the glove and then you have it where only your skin's touching, okay? So quick videos, like I mentioned, and let's take a look. So you see, he took off the gloves at the same time. And everything that was contaminated blood is inside the gown. And so that's where I said, like, if for some reason your gloves are on, your gown is off, you still do glove to glove, skin to skin. And the biggest thing is we are just trying to make sure that you're protected, you're learning aseptic technique. And even though the case is over, you still don't want anything left on you. Okay. Now you're getting ready to open a case. Okay. So I am sharing my video with everyone right now. It's about 28 minutes, like I said. Um, and it kind of breaks everything down. But the biggest thing is we usually start our timing 15 to 20 minutes before the start of a case um, for less complex surgeries. So, like, let's say you have lap appy, those usually take about 20, 15 minutes to do. So you can open up a little bit closer to the case because it's not going to be that much to open. But let's say you have a huge heart transplant. you're going to need a little bit more time because you're going to have a lot more intricate instruments. You're going to have a lot more sets to open. Same if you're doing a totally arthroplasty, um, you may have double brings, double back table. You may just have more stuff. So you're going to allot for a little bit more time. So items that are going to be open, you're going to have your linen packs, your instrument trays, your basins, your sterile items, usually in that order because you're opening up your sterile field. The things that you're going to be doing, the video shows you. You make sure that your furniture, your equipment is in the right place. How do you know? You check your surgeon's preference card. You double check that all your items are sterile, meaning you grab the item. Okay, I have something with plastic in it. Okay, we're checking the plastic. We're checking for integrity, sterility, punctures, holes. If it's manufacturer, we're just making sure that it's intact. And you see kind of like how he's opening up the cover sheet. That's all that is. That plastic is just cover. And then you're looking at it. You're making sure that everything is where it needs to be. And you're monitoring your sterile field. When you go to scrub your hands, you have someone, hey, I'm getting ready to scrub my hands. Can you watch my sterile field for me? Because you don't want anyone not there, right? Um, we look at our pill pouches. They're delivered to the scrubbed surgical tack. We just make sure that everything is sterile. One of the things that you'll notice in here is you have your countables separated. Okay. You don't want to have everything all over the place. I constantly tell people that are in the lab with me, move with a purpose. You're visualizing where you want things and then you place them. Sometimes I'll joke and be like, "Oh, you're trying to get your steps in." That's a hint. That means you're kind of doing too much, okay? Because every second counts, right? And even though emergency situations are rare, I like, because I'm a trauma, I like to be ready. So I'm going to move fast. I move fast, I set up, and then I break. And then I'm available for my circulator, for anesthesia. Sometimes a surgeon may need stuff. And then I scrub back in. Okay. But you will get there. So you'll notice that we'll have things put on certain sides. All right. And you want to have your circulator pour your fluids carefully. You're trying to make sure that they are not pouring stuff like we saw in the video where he just poured and it fell on the mayo stand. And you're like, dude, what are you doing? All right. You're maintaining sterility to prevent contamination. And we look at the sterile field. Okay. The next couple videos I'm going to share with you guys because we are getting short on time. So I'm going to share these videos um, in Moodle. So you guys will get these. So don't stress. But there are do's and don'ts in the operating room. Okay. When a person is not fully committed to the importance of aseptic technique and aseptic principles, they may become complacent or they may neglect procedures. Some individuals may not even realize the consequences of disregarding sterile practices or may become disengaged from the process over time. Sometimes that happens. Failure to follow aseptic principles leads to SSIs. That is something that we do not want, right? Like we're here for our patient. We have universal precautions. We talked about it. Hand hygiene, our PPE, there's health policies. And if you're sick, we want you to, take care of yourself. Okay. We also look at our exposure. We're in a field that unfortunately we may be exposed or we are exposed to different pathogens. There are different regulations for handling and disposing of sharps. We're trying to minimize the risk of needle stick injuries and contamination. You're going to be taught the neutral zone. There are some facilities that require students, preceptees, to hand things in a basin versus by hand. Okay. That's just what the neutral zone is. It's just you have a space where you have sharps and that's where it'll be passed back and forth. It's like the no touch technique. And one of the biggest things to remember is to err is human. Okay. Human error is a significant factor in exposure, which is why careful technique awareness and teamwork is going to be important just in maintaining safety. But we do have post-exposure prophylaxis. It's going to really depend on your facility, how they approach it. but it refers to just the immediate medical treatment provided after potential exposure to infectious materials like HIV, hepatitis, and you're just trying to reduce the likelihood of the reaction. And of course, there's precautions, okay? We're going to clean our hands. We'll have our appropriate name of whatever the precaution is on our rooms. We'll have the appropriate mask, everything on our rooms. A lot of times facilities will just get you all tested for N95 respirators, which is a high level protection. We have the negative pressure rooms, like we mentioned, and it's all just to prevent the spread of airborne pathogens. And the last thing is medical waste. It's going to refer to solid waste generated in our settings. That could be from diagnoses, treatments, immunization research, or even the production of testing of biologicals. So there are federal agencies that have regulated medical waste: EPA, the FDA, OSHA, NRC, which is our Nuclear Regulatory Commission. There are also state level regulations according to the book, and healthcare facilities that we just have to comply because we deal with this stuff day in and day out in the operating room. I know there was a lot. I will also be sending you guys the Quizlets. The quote of the week we went over in ST 310, which is a little bit different. For those of you who are watching, how can we balance the need for strict aseptic practices with the potential for human error in the operating room? In what ways can the surgical team maintain a high level of motivation and accountability for infection control, especially during those long and routine procedures? And how might the design of the surgical instruments and environments be improved to just really further reduce the risk of contamination during procedures? You guys, I'm really humbled that you guys have stuck it out. I know that today was a lot longer than we normally have. We did review guidelines related to what we're going to be doing day in and day out as surgical technologists. There's barriers, containment, confinement. We looked at the importance of maintaining sterility. We had a lot of videos breaking down gowning and gloving ourselves, our assistants. We looked at how the operating room works and how it's built in a way to help prevent SSIs. Okay, we looked at the principles of standard precautions, and we touched on some of those um, important concepts and components that are put in place just to help us protect ourselves. I encourage you guys to keep moving forward. We're almost there. Next week is week 8. And I do look forward to everyone who can attend next week's live session. Again, I'm very humbled for you guys sticking around this evening. You guys have definitely deserved a nice break. You guys have a wonderful rest of your evening, a wonderful rest of your week, and good night.